Our presentation is on lung cancer. My name is Kimberly Acosta.
I'm Don DeMavo.
Mariana Edwards.
And I'm Bridget Hunt.
Lung cancer has a poor prognosis. Over half of people diagnosed with lung cancer will die within 1 year of diagnosis. The 5-year survival rate of lung cancer is less than 18%. Non-small cell lung cancer accounts for the majority of all lung cancer cases. Lung cancer morbidity is strongly correlated to age, and treatments for lung cancer include surgery, adjuvant, chemotherapy, radiotherapy, biomarker testing, and immunotherapy.
How does lung cancer start? The origin of non-small cell lung cancer, NSCLC, comes from adult lung epithelial stem cells called bronchoalveolar stem cells, BASC, located at bronchial alveolar duct junction, BADJ. SCLC, small cell lung cancer, are primarily localized in the mid-level bronchioles. In NSCLC, we see mutations and abnormalities in the following genes: P53, RB, and MYC family members.
Some of the cells and tissues that lung cancer can affect can include the bronchial areas, serous membranes, the alveoli, the airway epithelial cells, interstitial structural cells, and the endothelial cells.
The immune response of lung cancer starts with inflammatory stimuli such as inhaled molecules, which increase the number of alveolar macrophages, therefore activating them to produce pro-inflammatory mediators such as cytokines. Alveolar macrophages 1 and 2 are producing cytokines such as IL-12 and IL-10 respectively, and they work against tumor cell invasion. And M2 macrophages work towards promoting tumor progression as well. Neutrophils are one of the first immune cells to be recruited to the lung tissue. And upon degranulation of their granules, they stimulate mucus production and amplify immune responses. And dendritic cells, which are the main APCs that migrate to lymph nodes, have contact with the cancer antigens and therefore activate effector cells by presenting antigen to them, which results in antigen tolerance, priming, and triggering of the effector T cell responses.
Some of the cells involved in the immune response are natural killer T cells. They direct cytotoxicity, death receptor ligand expression leading to apoptosis, and they produce immune active cytokines. Another cell would be the myeloid-derived suppressor cells. They suppress T cell activation and sustain tumor growth. Robust cytokine response is critical to stimulate adaptive immunity. B cells, they produce tumor-specific antibodies such as LAGE1, TP53, and NY-ESO1. Some other cells involved in immune response would be CD8 T lymphocytes. They're cytotoxic T cells. They mediate anti-tumor response. And lastly, CD4 helper T cells, Th1, Th2, Th17, and regulatory T cells, also known as Tregs. They prevent the function of CD8 T cells, promote tumor growth, and Tregs cells function for surveillance and tolerance. And some symptoms involved with lung cancer: tumor growth at the site of chronic inflammation caused by infectious pathogens, coughing due to bronchial compression of tumors, bloody sputum, bronchitis, dysplasia, which leads to shortness of breath. And in some cases, you have some rare symptoms, which include shoulder pain, Horner syndrome, hand muscle atrophy, superior Sutcliffe's, or Pancoast syndrome, which is because of carcinomas located at the apex of the lungs.
some immunological effects we can see from lung cancer. If the immune response is functioning as it should perform anti-tumor responses that would allow it to eliminate the cancer cells. But at times they're not able to completely eliminate all cells or cancer cells, and further tumor growth can happen. Either the tumor cells are able to proliferate without any restriction, or under the correct conditions, it can favor tumor growth. And a study on NSCLC, there's 3 phases, which is the elimination, equilibrium, and escape phase, where elimination phase is where the immune response is eliminating cancer cells, but there are some cells that are able to evade it, which goes into the equilibrium phase, where some of these cancer cells can lay dormant until selective pressures or changes in the immune system, for example, the immune system is weakened over time, allow the tumor cells to continue proliferating to the point where it enters the escape phase, where the immune system is no longer able to recognize the tumor cells and they can grow unrestricted. Another aspect to look into is the CTLA4 and the PD-1. As the functions of the immune response become impaired, tumor cells can take advantage of the situation to continue growing. And Kim will talk more about these certain scenarios.
Impaired functions of the immune system in lung cancer include lung cancer cells hiding against cytotoxic attacks by low antigen presentation and low co-stimulatory molecule expression. Functions of the professional APC, such as dendritic cells, are compromised by the tumor education and contribute to cancer immune evasion. Mechanisms of the cytotoxic lymphocytes inhibition include the PD-1 receptor on lymphocytes that bind to the PD-1 ligand on tumor cells, which suppress the cytotoxic lymphocytes' cytotoxic function and leads to apoptosis of the cytotoxic lymphocytes. Also, we have the CD80 and CD86 on APCs that interact with the CTLA4 and competes with the CD28 binding, which inhibits TCR activation on T cells, therefore inhibiting the activation of cytotoxic effects of these cytotoxic lymphocytes. We also have interaction of FAS and FAS ligand, which causes the cytotoxic lymphocytes death due to high expression of the FAS receptor on CTLs and high expression of the FAS ligand on cancer cells. This interaction leads to apoptosis as well on apoptosis of the CTLs. And then we also have tumor-associated macrophages, which are dominated by the M2 phenotypic macrophages that promote metastasis and angiogenesis of the tumor cell. And TAMs also have poor antigen presenting capacity, and they also suppress T helper 1 adaptive immunity response.
Oh, here's an example of cigarette smoke affecting epithelial cells on the far left. Over time, it'll start to impair the immune function, allowing viruses and bacteria to also start colonizing an already immunocompromised host. And over time, it just has detrimental effects to the host. And if this is a localized area, imagine how cancer can spread throughout the whole body, starting from lung cancer.
So immunotherapy is a treatment for lung cancer. Essentially, immunotherapy drugs block the tumor cells from deactivating T cells. So we have cytotoxic T lymphocyte-associated antigen 4, which functions to so these function to inhibit the binding of the CTLA4. And then we also have the programmed cell death, which prevents T cell activation through downregulation of the immune system and promotes self-tolerance and reduces autoimmunity. And then we also have immunotherapy through vaccines, two of these immunotherapies are tumor vaccines and antigen-specific immunotherapy. Tumor vaccines are developed from allogenic tumor cells, and the tumor vaccines work by exposing the host immune system to various tumor-associated antigens. And the antigen-specific immunotherapy incorporates specific anti-tumor immunity against antigens that are expressed on tumor cells.
Now, we've seen that eliminating cancer cells from tissues through immune responses alone is very difficult, and lung cancer is also hard to diagnose and treat. So there are several questions yet to be answered, and we're going to look at some current research and open questions. Some of the major open questions are in the areas of diagnostics, preventative treatments, and more recently, lung cancer in COVID patients. One big open question in the area of diagnostics is how we can catch this earlier, because the sooner lung cancer is caught, the sooner treatment can begin and the higher the chance of survival. A possible target includes looking at specific markers of lung cancer, such as tumor-associated autoantibodies, which are antibodies that attack self cells, and also looking for PD-L1 ligand on the surface of tumor cells. Using such markers could lead to highly improved diagnosis, and therefore it's important to continue to look for more autoantibodies and other biomarkers that may be specific to each person. And this can be done using detection assays like a sandwich ELISA. With treatments, a big question in the newer area of immunotherapy, aside from what was mentioned previously, includes how do tumor-infiltrating lymphocytes function during the stages of lung cancer. To study the function of these cells, flow cytometry could be used after T-cell receptor stimulation to examine cytokine production and activity at various stages of lung cancer. Also, in light of the current pandemic, another question that researchers are looking at is how does coronavirus affect patients with lung cancer? In a recent retrospective study examining 102 patients, it was found that COVID-19 is associated with a high burden of severity in patients with lung cancer. But it's still not fully understood how coronavirus affects cancer progression. To help answer these questions, tumor-infiltrating lymphocytes could also be analyzed during co-infection and after recovery of coronavirus using flow cytometry methods. These are just a few open questions in the vast ongoing area of research on lung cancer. And despite knowledge gains that have led to targeted therapies, mortality rates from lung cancer remains high for most patients around the world. Lung cancer in general is the leading cause of cancer death worldwide. It affects people who smoke, and it's present more in men than women, and also more so in the elderly, around 60 to 70 years old. The highest incident rates are in Europe, Western Asia, and certain parts of Asia like Turkey and China. Currently, lung cancer cases worldwide are on track to increase by 38% to 2.89 million cases by 2030. These statistics show us just how many people would benefit from the research and information gained from lung cancer advances in treatments and diagnosis, especially those who are male, people who smoke, and in the elderly. And that's why it's important to have proper funding for this area of research. Currently, lung cancer is funded by many associations, as shown here. With these funding resources, improvement in early detection and technological advancements for treatment are made possible, and ultimately, they have helped support many improvements in lung cancer survival worldwide. And that's our presentation on lung cancer. Thank you for your attention.